welcome to Clinical Unfiltered, which believe it or not, we're going to unfilter dentistry today. So give me your hearts, your minds, your teeth, and let's get going. Today, I'm Dr. Sausha, and today with me, we have Dr. D, a good friend of mine out of Tampa, and she was the one who actually first introduced me to the importance of airway and in dentistry, and even just airway in total. I am guilty of not going to a lot of CE, even though I love learning new things. I hate sitting down and listening about new things. So I actually don't physically go to CE. And so when Dr. D was like, hey, I have this event, I immediately was like, no, I'm not going to that. My wife happens to be a speech therapist at the time. So I'm like, oh, okay, this is something we both could go to. So we went, and it was about airway from the Breathe Institute. And that changed my whole perspective on airway and dentistry. Dr. D, do you have that? And I feel like a lot of people have that moment where oh, it clicks. Airway is important to dentistry. What was your moment?
My moment was when I was struggling to nurse my second-born son and not understanding why it was so difficult. And I went to the pediatrician and I said, is this a lip tie? And he said, yes, but he's a boy. So the first time that he falls, it will fix itself. And so we only ever refer out if mom's in pain. So that was kind of like a light bulb moment for me, because I'm like, well, the bottle doesn't know pain and it's about dysfunction, but in my fight or flight with all the pain, I was like, okay, so what's the next step? And he handed me a paper and he said, this is an ENT and this guy's a dentist with a laser. And it was 2019. And at that point, I'd been doing laser dentistry, since 2014. I had 2 powerful hard and soft tissue lasers in the office. So I knew the difference between a dentist with a laser.
That's right. I remember that. I remember you almost had in the name. It was like,
yeah, laserdentist.com. And so I was like, it's kind of like I marched this poor kid across the parking lot to my office, had my assistant, hold him down and released his lip tie, himself. And things immediately improved pain-wise. But then when we exited that 4th trimester and milk supply, it becomes supply and demand regulated and not hormonally regulated. So the guy couldn't lift up his tongue to demand the milk. So the pain returned. And I was discussing it with some of my colleagues in my mommy dentist and business group. And they're like, maybe he's got a tongue tie. And I was like, what? And I read Tongue Tied by Dr. Richard Baxter. And I was like, oh my goodness. And I always felt like I was in my zone of genius. I felt like, I was doing general dentistry. I was doing it from what I thought was a comprehensive point of view and looking at the patient as an individual and a big picture and not just one tooth at a time. But I remember clearly walking in one day and telling my then associate, who has now purchased that general dentistry practice, I remember telling her, I found my calling. I found my purpose. I really want to help moms, through this journey. And I want them to be able to end that journey on their terms and not because of miseducation or missed education. And so I was nobody in Tampa Bay, was really doing it from this point of view. So I really wanted to dive into that. But then once I, was seeing more and more patients coming back from maternity leave, I looked at my adults with a whole new lens and I was like, oh my goodness. This is something that we've been missing, and it was variable. It was some patients where they would come in and do a hygiene check and they would have cavities every single time, but we would be able to tell that they were genuinely trying. They were increasing, they were improving their oral hygiene. They were working on their technique. They were giving a shit and they were doing what we recommended, and they were still having problems. Or the ones that are just gagging every time you put something in their mouths, or those patients that you're fighting their cheeks so hard that you're non-dominant hand and shoulder and arm are like breaking down at the end of the day because they're just trying to maintain an airway while you're trying to do dentistry, and the two just don't go together. And I looked at them with a different lens and I'm like, wow.
I mean, what was the time frame on that? Like, I mean, you said 2019, kid has issues. You do the you read the book before you did the tongue tie release?
Yes. Actually, I had a colleague in the area release his tongue tie initially, and it was a little bit more fascial, more involved for him. So I had to keep digging down deeper, and I just found myself into the bottom of the rabbit hole. So because of this pandemic, I was able to stop, as many of us were, and without the distraction of clinical dentistry, I was able to then take more coursework. So I initially started with just like a pediatric tongue tie course, and that kind of got me started. And then I took the Breathe course with Dr. Sarush Zaghi and the Breathe Institute, and that tumbled me in. I did the whole like curriculum with the Vivos Institute. So that was a great background for sleep disordered breathing and how dentists can really help with that.
So that institute does tie it to dentistry.
Yes, I mean, there are many dentists that, provide oral appliances through the Vivos Institute. And, while I'm a Vivos integrated provider, like by training, I just kind of resonated a little bit more with the Breathe Institute and found that for me personally, my zone of genius is more so in the treatment planning, the bringing together of a team, the recognizing of how these restrictions have manifested for the individual, because we don't grow out of ties, we grow around them and we compensate for them. So it really frustrates me to hear when someone is told like, oh yeah, that's a tongue tie or that's a lip tie, but they'll grow out of it, because I feel like that really discounts us as human beings that were designed to thrive. Like we're way smarter than something, that's
to grow out of it. So I mean, let's clarify this. Do people grow out of their tongue ties?
Absolutely not. And it's so it's I think disrespectful to the patient to just be like, I see tie, I cut tie, because it can be so much for that patient in ways that we're really just not taught as dentists to understand. And only because I've retired from restorative dentistry, have I been able to dive into what that really means, like how oral ties can manifest with straining of the cranial bones and anxiety and what it means beyond sleep. So, we can get really eager with the ability to help a patient with their sleep and not really understand that that's a little bit short-sighted, because that release of fascia that's really pulling up into the oral cavity, like that has an impact in the rest of the muscles and how the body aligns all the way down to the feet. So kind of like when, I was in dental school and as a really eager dental student trying to just make it through clinic, right? We go into the office and be like, oh, Dr. Paul, like I have a crown, I have a denture, very like short-sighted. And he would say to me, but what about the patient? Step back. Let's look at the big picture. Beyond this one crown, what's going on with the rest of the teeth, what's going on with this patient. So that was really impactful, I think, in my training. And so we can look at a patient and understand that there's a concern with the quality of sleep, because as dentists, we were asked, there was a call to action to say, it is our responsibility to start screening patients for breathing disordered sleep, because they see us more often than they see a primary care physician, if they have one at all, right? So we see these patients, we're identifying all these signs in the mouth that there's dysfunction in the way that they're sleeping at night. And then we are like, oh, I recently heard about tongue tie and it's very clear that you have one. Let's just go ahead and release it. And there's this really beautiful honeymoon phase where things like really improve. But again, that short changing our brain and our nervous system and our ability to adapt. Because once that honeymoon phase is over, that doesn't mean that this really under-respected muscle, the tongue, knows where to go and what to do. So after that initial like, wow, we just took away a lot of tension in the body, some patients can really be set up for a healing crisis. And so really doing like a full case workup is, I think the most responsible way to.
I think a good way to kind of move into the work. So pandemic hits, you established this practice to be mainly airway based.
Well, when I came back from the pandemic, I was like, well, how can I just kind of,
how'd you set up your practice? Yeah. How'd you make this transition?
I'm already doing. And so I was, getting patients coming in very organically, because the Breathe Institute, once you take their course, at least at the time, they were updating like a directory of providers. So if you take the coursework, you're known as a Breathe Institute ambassador, right? You've taken the coursework. And so while we dentists were learning more about this, there was also a boom in myofunctional therapists, and they were also training through the Breathe Institute. So I would have patients call up and say, I've been referred by my myofunctional therapist, and that myofunctional therapist might be in Seattle or Las Vegas, but they're finding me, they're treating these patients online, and then they're looking at a directory to see who's a release provider that understands the importance of myofunctional therapy and body work. So then they refer to me. And
how many of them are there regionally?
I mean, at this point, there's thousands across the country, So, but I kind of had enough where I opened my eyes and I was like, hey, I'm getting completely random patients that they already have general dentistry homes, but they're coming to me because I've taken this coursework with the Breathe Institute. And that's like, from a business point of view, the fastest return on investment I've ever seen with any of the CE that I've gone into, right? It was very low buy-in for like the CE, and I naturally had good surgical skills from my training. And so that paired pretty well. And so I was like, I should lean into a little bit more. So I went back to the Breathe Institute. I applied to become one of Dr. Zaghi's affiliates, which means that we're personally trained one-on-one by him, not just, a registered attendee of his course. So he, has built up this reputation. And in order to say, I've personally trained this doctor, he needs to have that doctor in the office to work up cases together. Then we go and work up cases. And he stood over my shoulder, just like dental school, watched me perform surgeries, like ego aside. He's, I'm in the middle of a surgery and he's saying, Dr. D, can you identify this structure that we're viewing here? And I'm like, yes. And he's like, well, just for practice sake, can you go ahead and take, this instrument and point to it and call it out to me, right? Like, he wants to make sure that if he's going to put his name next to your name, that your stuff. Because honestly, people watch his videos and then these doctors reach out to him in the middle of the night, time zone change. And they're like, I have this bleeding. I have this complication. Like, what do I do?
Oh, wow. Okay. Yeah. From the surgical procedures that
the surgical procedures, I feel very confident that they learned through his course, right? So if he's going to say, this doctor is an affiliate personally trained by me, he's got to know that we know our stuff, right?
So it was through that process, then you were like, all right, we're going to implement more of that workflow as a part of the clinic.
Now, like, that's a little bit of a process, right? For me traveling out to California and then coming back, working up cases, and him coming here. So that was between 2021 and 2022. So after I finished my program with him and I'm an official Breathe Institute affiliate, I created a separate entity. And so I was seeing those patients through that entity because I didn't want to muddy up my new patient numbers, right? Because these are patients that are coming for recall. So then that's totally throwing it off.
Well, it's good. Then you're able to monitor the flow of How many am I getting this way? I got you. That's a good way to kind of keep track of the two funnels, basically.
So I started doing 2 days a week of just, airway hat release provider and 2 days a week as like primary care general dentist.
Gotcha. Okay, so designated days.
So that because it's really difficult to shift back and forth mentally, and then these patients, these procedures, they really need you to be in there in the moment and grounded and not running off to a hygiene check or a seat down.
No, that's smart. That's smart. I mean, I could imagine trying to switch those hats. I mean,
It's challenging, and then that's like very exhausting at the end of the day.
it's almost like running two practices in that same practice then. Gotcha.
So then I found the benefit of physically separating out those 2 days a week. So I then evolved to subleasing space in an ortho colleague's office. So then I didn't have the sounds of a dental office that can be triggering to someone. And if I'm asking them to really go through their history and really trust me with a lot of these things, but they're being triggered by sounds and smells and energy, that I felt was also important.
Gotcha. Wow. Okay. So, and I mean, how long did that process take from like injecting it into your clinic to transitioning to a whole separate space?
Very quickly. I think that when something is, when you're really passionate about something, it becomes like very organically driven. And so it was April of 2022 that I completed my affiliate program. May that I was like a separate entity, and then July that I moved.
Oh, wow. Jesus. That is quick.
It really wasn't long before we had like a month like wait list to get onto those 2 days.
I mean, now that you've completely separated out that clinic, now granted, you had a moment where they were together, and I know we have listening dentists who probably are interested in implementing airway dentistry. What would be, so your referrals mostly were coming from Breathe Institute, but let's imagine, I'm assuming you had patients of your own, they were seeing as new patient dental,
I will say like that transition from the general dentist patient, like that is quite difficult, okay? Because they come in, they're used to seeing you, if it's a hygiene visit, they're used to seeing you for a relatively quick exam. I tend to get long-winded and go into things, but really they're prepared to come in to only share so much about themselves with you, right? So they're like, oh, she's going to come in, she's going to check, she's going to tell me if she's going to ask me how often I'm flossing. And, are you sensitive over here? And how's that doing? They're not really prepared to be like, how are you sleeping at night? How do you care for yourself? How would you identify, like the number of patients that are like, I sleep just fine. I sleep so well, I could fall asleep here or anywhere. And we're like, actually, that is.
Yeah, right. That's not good.
Like if I can just walk out of the room and you can fall asleep, that's not good sleep. But they're like, whoa, I wasn't prepared to talk about this. So that transition takes quite a lot of like finesse. That is a little bit of a build. So I will say that the majority.
What's your lingo? What do you say that like, how would you transition those patients into that conversation when they're in the chair? Like what stage of the consult are you like?
Well, I would typically, my point of view would be like, not to be over the patient, because that's a very like dominant position, right? To sit the patient up, I swing my chair around so that we're really like eye to eye. And then I ask the question, right? And so if they're kind of like defensive and deflective, I kind of try to just plant little seeds and then make a note to follow up with them subsequent appointments. But if it looks like it's really, if they're hitting that like straw that broke the camel's back, where they're coming in and they're having TMD and they're breaking teeth and their restorations are not lasting, that's like let's really have a conversation. Like maybe let me give you some resources, and then it might be a good idea for you to come in for a separate conversation about this. Or
like you're going to find different severities. You're like, hey, this person, we'll touch on it today, but it's important. We'll bring it up. But then there's someone you're seeing, you're like, your sleep sucks. We need to fix this right now. Like, sit down. I'm the Sandman. We're going to figure this out.
There are different like phenotypes, right? But like for women, we're kind of designed to just like push through and get things done. But then when menopause hits, it's like so much changes that those patients, they will really come in looking completely different than the last recall. And it's like, wow, let's have a conversation. I'm really concerned about this. And one entryway could be, if you get, for example, a couple sleep image rings, and you pay like the monthly to do however many like screenings per month. And then you just like loan them out to patients and say, hey, like very low buy-in. I'd like to screen your sleep. If there's more to discuss, we can really make a separate appointment for that or make a referral to your physician. But I am seeing signs in your mouth that something's going on when you're unconscious that's affecting your quality of life during the day. And that can be really important for your quality of life.
Gotcha. So what is your screening? Like, what is your process in screening them and helping diagnose them before you move on to the treatment?
So now that I'm completely removed from that, right? So they're kind of pre-screened when they make it to me.
Gotcha. Let's pretend before that. Let's go back. Let's wind it back for the dentist.
So before that, like you can look up sleep image tests. We would call them screenings because as dentists, we can treat snoring and sleep apnea, but we're not allowed to diagnose it. So I would always be very careful to be like, this is a screening, and I'm not licensed to diagnose you, but based on it, we can know if that's like important for you to follow up with a primary care physician, a cardiologist, a pulmonologist. If these screenings are coming in as, moderate to severe sleep apnea, you really need to make sure that you've made that referral to the MD so that you're not risking anything license-wise, right?
Did you find any specific ones to send to, or you're just like, go to one, insurance, whatever?
So it's kind of a discussion of like, if you want insurance to pay for like your formal sleep test, or you're looking at that screening, if there's like central sleep apneas, maybe you're like, okay, let's send you to the pulmonologist. They'll probably, bring this information so they can use it. Maybe they'll set you up with an in-lab sleep test. Otherwise, at very least, like, do you have a primary care physician? If you do, then return and bring this information with you, right? Because before
So it's a referral through the primary care too.
Yeah, before I was providing those screenings, I'd be like, oh, I see this. I would follow up with your primary care physician. I had a patient come back and say, oh, my physician said I'm fine, but we're titrating my hypertension medication. And I'm like,
Well, it's the same thing with a specialist. I feel like if you're on the same wavelength, they almost know why you're getting sent. Whereas like if you send it out to the random pool of doctors be like, sleep apnea, what? Get out of here.
It's not really my role to know which, who they're supposed to.
Gotcha. I was just wondering. I was wondering if that was a part of the game, is like you do have specific referrals or not, or
I try, but like, I've tried to reach out for lunch and learns, and they're like, we don't really have time. We sit there with a dentist, right? Who caught something that I didn't see, right? So is that the best use of my time? Probably not. So what I did instead was like, I'm going to give you something tangible that they have to look at. You bring in this record, it shows how you're sleeping. It gives them information that like medical legally they have to look at and have an opinion about, whether it's, if you go in and you have all these like apneic episodes that are shown on a piece of paper, I doubt that your primary care is going to be like, oh, you're fine, but let's just increase your hypertension medication. You're going to have to say, oh, that's concerning. You didn't really fit, my screening criteria for sleep apnea. Let's refer you to this individual, because I don't know how their medical insurance works to be like, do they have to go to primary care before they go to the pulmonologist?
No, but I get it. Sending them with data that's king. That's clutch right there.
They can ignore my phone calls, but they can't ignore this patient coming in with like that data.
Beautiful. No, okay, that's great. I feel like I really actually could overcome a hump for them in the process. Yeah. So they get sent off. Now, as far as like you've diagnosed them with a certain level of airway issues, what levels are you actually like implementing therapy of your own? Like so you send them off, what happens next?
So my goal is to meet patients where they are. I've kind of like become synonymous, I think, in the community with like a root cause holistic approach where you really have to put in the work to understand what's going on. However, I do recognize that not everybody's ready to put in that work. And so if you come to me, I might be like, yeah, you got a tongue tie, but like it's definitely not a good idea just to release it. I would want you to do myofunctional therapy. If we're seeing postural changes, if we're really seeing like a lot of asymmetries in their cranial structure, like that one eye is, kind of pulled down, one ear is flared out, we're going to have a discussion about that. But sometimes when we're sleeping so poorly, someone's sitting there and talking about all the work that you have to put in, it's a little, you can't really fathom and entertain that conversation. So for me, it might be, I've done the dental sleep medicine mini residencies for both adult and pediatrics with Tufts. And so I might talk about a mandibular advancement splint device as something to help them start to sleep better. And if they're coming in and they're like, that's all I can handle right now, and I'll follow up about that, then that's great. Or if it's like, I can't, like, I have such a gag reflex, I can't tolerate anything in my mouth, then I'm going to talk about nightlays, which is a non-surgical light therapy that helps to open up the airway, reduce inflammation, improve tissue tone. It really helps with gag reflex. And so that can help with sleep. And then they just have to like show up once every 3 weeks for 3 to 4 sessions and follow up there. So my hope is like, if I can get them sleeping a little bit better, they kind of get addicted to oxygen and deep sleep. And then they're like, what can I do to help make sure that I'm on a good path to maintain this for myself?
Gotcha. So you have follow-up sessions set up specific. I mean, again, you're not like, I feel like most dentists who do this, they have follow-ups just because they're doing regular dentistry and hygiene visits and things like that, but you're doing actual designated follow-up. So you designated the level or severity of their sleep apnea or airway issues. And most of the time you are correlating this to sleep.
I mean, if you're oxygenating, if you're breathing poorly when you're conscious, it's like, how could you not when you're asleep, right? The way that I describe it is, it's our brain has this long to-do list of things to get through at night, right? And it's kind of like when you update an app on your phone, right? And you're like, I updated the app. I don't understand why it's not working. And then you power your phone all the way down and you power it back up, and magically that same app is working just fine. Like that's what we're supposed to do when we sleep. We remove the bugs, right? We debug the system, we update, right? And so, for example, with rapid eye movement sleep, all of our voluntary muscles, except for our eyes and our ears, become paralyzed. And how would your brain know? Like, I know that we are evolved. We have security systems and lights all the time, but how does our brain really know that there's not going to be a bear coming in and attacking us, or, a burglar? How does it know that it's safe enough to paralyze the very muscles that would allow you to run away? So oxygenating, how you oxygenate your body is that chemo signaling to say, we're in a safe place. We can go into those levels of sleep where we know that we're in a safe place. And it's really important for, cleansing our brain of metabolic toxins and protein byproducts, protecting our like emotional wellness, our immune system, removing, activating that glymphatic system and moving short-term memory to long-term memory, right? So like, what is brain fog?
No, I mean, sleep has definitely taken a huge turn in our understanding of general health, for sure. I mean, I feel like I've listened to this one podcast that talks about longevity, and it's like naming the 5 things you could do, and like on there, 2 of them deal with just sleep, like the chronicity of sleep and the amount of sleep.
In general, too, like as a culture, we kind of pride ourselves of like continuing to go to work when when we're breaking down and like just NyQuil to get through the day because we're well respected if we work ourselves so hard, right? Instead of
Right. And that's okay. But we got to sleep hard too. As far as like diagnosing, like figuring, well, I guess you can't diagnose, but like when you're trying to figure out their airway severity issues, I mean, there's obviously anatomical components. Are there other components to their airway issues that you're assessing?
Yeah. I mean, I kind of nickname them neurological restrictions. So you have the physical restriction of the oral tissue, right? So everybody, and I really try to stay away from saying severity, right? Because let's say that you have like, and correlating that severity with where the attachment is. So if there's like a class 4 lip tie, is that more severe than a class 2? I don't put on my notes where it attaches and have that tell me if I should treat or not, because everyone's different. We might have someone with really elastic tissue. Maybe they have a connective tissue disorder and they feel really loose and they're hypermobile. And it's like, oh, well, they feel really loose. But that little amount of tension can mean a lot for their breathing mechanics and their autonomic nervous system regulation, right? So I try to stay away from telling patients what they need and how severe things are and just try to like learn them through function so I can make recommendations and see what resonates with them personally. But you've got the physical restriction. So the mucosa, where it attaches, does it pick up the fascia with it? Does it restrict the glide of the fascia? And then therefore prevent the full range of motion of the muscles as we're expecting them to move, right? And function. Then I have what I call like neurological restrictions. Is the tension from the fascia like so tight that it's creating tension in the positioning of the cranial bones and perhaps compressing some of the cranial nerves that are actually telling the muscles what to do? So if you have compression of how many nerves tell how many muscles what to do for a really functional, well-coordinated swallow pattern. And if some of those nerves are compressed, like you could do myofunctional therapy all the time, but if the nerves that are telling those muscles how to move, the patient just won't really get it. You can cut the tongue tie, but if the tongue doesn't know how to move, and that's why some patients, they have a tongue tie release and sleep actually gets worse. It doesn't know where to go. So then it just falls back into the airway.
Right. I mean, I remember my my initial I watched YouTube videos on when I first got out of residency and was still doing tongue tie releases, and I wouldn't do a lot. I mean, I wouldn't get sent a lot, but if I did, they'd be sent as frenectomies, and then come in, I'd look at their frenums and be like, huh. And then in the tongue, I was like, oh, okay, the tongue. And then I would look, and this is like, I'm sure the general process of most surgeons who do tongue ties. I used to, at least because my wife was a speech therapist, then say, hey, we need to teach your tongue how to move now. Like there's movement there. The muscle still has to change, not just me cutting this. And so I would at least guide them through some of the videos, but it was rough. I mean, it was a rough draft of what they should be doing. And then I would just get so lazy. It's like, hey, here are the videos. Go look at the videos and do what they say. And then I stopped. Then I just send to you. And then we took it off. I was like, just take frenectomies off. It's not a real thing we do. That's getting me boiled down to actually where. So I wanted to get through some of your diagnostic process. And this is what I really did think it was. It was layered. It wasn't like, oh, tongue tie, cut. It wasn't like, oh, you sleep crap. Here's like a thing you put in your mouth to fix it. It's a little bit more layered than that. Before we kind of move on to therapy, what's a good resource to develop a little bit of better understanding, a holistic picture of the patient prior to jumping into some kind of therapy? What's your favorite resource? What would you recommend as a resource?
A good start would be the Breathe course through the Breathe Institute. That I think they do a wonderful job of connecting airway and sleep and function all together, and kind of respecting that it is a process, and how it can manifest differently for different individuals. And I do the same thing. I look at my babies no differently than I do my kiddos and my adults. It's just some people can communicate more than others.
Yeah, I feel like Dr. D does have a vested interest. I don't have a vested interest in the Breathe Institute, but just hearing their methodology and their thought process did click for me. So I would second that. I think that is a good source.
There are other resources. I mean, if someone was actually interested in, doing, oral appliances, or, just starting with the Academy of Dental Sleep Medicine, it's not going to be fully into like tongue tie, right? But it gives, I think, good baseline knowledge for sleep and breathing mechanics. And they are starting to talk more about myofunctional therapy paired with, CPAP, myofunctional therapy paired with mandibular advancement splint therapy.
Gotcha. And those are myofunctional therapists. I mean, I know you have one or two in-house.
I have two in-house. One is oral motor therapy for the littles. Okay, so she is speech language pathology by license. It's not really myofunctional therapy until they're old enough to be led on their own, right? So it depends on the involvement of the caregiver. So if it's like 0 to 3 or 4 and the caregiver has to do everything, then that's more oral motor therapy. If they are like teachable, you can sit the child in front of the mirror, and then the caregiver becomes more like a supporting, guiding role, then that's myofunctional therapy. And that can be, it can be speech language pathology by license, PT by license, hygiene by license.
I have heard of the hygiene model, like certain hygienists who then go down that route, and then they kind of act in that role and within an office, because that is a critical part in getting if you want to get more invested into sleep therapy, airway, and managing airway issues, you've got to consider some form of extra therapy beyond the actual appliance or surgical procedure. So I want to talk about both those things: the appliance that you use or appliances, and then the actual surgical therapy. But I want to do it on another episode. Okay. So we're going to wrap this one up. Thank you guys for listening. Again, we do this at no cost to any of us. You are not getting paid, Dr. D, for this. But so please follow, click, like, all these things help us and keep us going. Thank you for getting Unfiltered today.